Hi guys, today I'm going to post, I guess, the shortest video of my entire series because the topic is actually very short. That's acoustic neuroma. It's a quick and a jiffy going to be get completed topic. So let's begin without any delay. Talking about acoustic neuroma is basically a tumor which occurs in 80% of the cerebellopontine cases and 10% of the brain tumors. So, what is it? It is a benign, it's an encapsulated and extremely slow growing tumor of the 8th cranial nerve, that is the vestibular cochlear nerve. Talking about microscopy, the elongated spindle like cells with a rod shaped nuclei lying in the rose or palisade pattern, and bilateral tumors are present in patient with neurofibromatosis. Talking about origin plus growth of tumor, it's always the Schwann cells of the vestibular or rarely the cochlear division of the 8th nerve within the internal auditory canal, and later it expands and appears in the cerebellopontine angle. Then classification. You can see over here one diagram. So as you can see in this diagram, this tumor is always arising from the Schwann cell of the vestibular and then but rarely from the cochlear division of the 8th nerve within the internal auditory canal. Now as this tumor expands, it causes a widening and erosion of the canal, as you can see, and then it appears in the cerebellopontine angle. So widening and the expansion and appearance in the cerebellopontine angle, and here it may grow anterosuperiorly to involve the 5th nerve or inferiorly to involve the 9th to 11th nerve. So can you see this tumor now has grown anterosuperiorly to involve the 5th nerve and inferiorly to involve the cranial nerve 9, 10th and 11th. And next what happens is in later stages it will cause the displacement of the brainstem, pressure on cerebellum and raised intracranial tension, and the growth of tumor is very slow. So depending on size, it is classified into intracanalicular, it is confined to internal auditory canal, small size, medium size and a large size tumor, as you can see. Talking about clinical features, age plus sex is 40 to 60 years and both sexes present. Cochleovestibular symptom, such as earliest symptom when tumor is still intracanalicular and pressure on cochlear and vestibular nerve fibers. There is a presence of progressive intellectual sensory neural hearing loss with tinnitus and is a presenting symptom. Marked difficulty in speech and understanding and out of proportion to pure tone hearing is loss. And then characteristic. Vestibular is unsteadiness in the working. Then cranial nerve involvement. 5th nerve, that is the trigeminal nerve, is the earliest nerve to be involved. This causes basically numbness. That numbness is basically reduced corneal sensitivity, and numbness is paresthesia of the face. Involvement indicate tumor is 2.5 cm almost and occupies the cerebellopontine angle. Next is 7th nerve. Sensory fibers are affected early. Hypoesthesia of posterior meatal wall plus loss of taste plus reduced lacrimation basically causes the delayed blink reflex early. Then there is the 9th and 10th cranial nerve, palatal, pharyngeal and laryngeal, which cause basically dysphagia and hoarseness. Then talking about brainstem involvement, it will cause ataxia, weakness, numbness of arms plus legs and exaggerated tendon reflexes. Talking about cerebellar involvement, pressure symptoms on cerebellum that is are seen in large tumors. Finger nose test, knee heel test are used. Increased intracranial tension will cause headache, nausea, vomiting, diplopia due to 6th nerve involvement and papilledema with vision blurring. Investigation and diagnostic audiological test may we have pure tone audiometry with airborne conduction. This will basically show a sensory neural hearing loss marked in high frequency. There is a speech audiometry in which there is a poor speech discrimination and rollover phenomenon, which causes basically reduction in discrimination score when their loudness is increased beyond limits. There is a brainstem evoke response audiometry, which is useful in retrocochlear lesions diagnosis, that is 8th nerve tumor less more than 0.2 millisecond wave file delay between 2 ears proves significant. And third is the vestibular caloric test. 96% causes basically cases are diminished or either absent. Then we have these imaging studies in which we have basically MRI with gadolinium contrast, CT scan, plain X-rays using Townes, submento vertical, Stenver and transorbital views. Then vertebral angiography will help to for a differential diagnosis from other cerebropontine angle fever tumors, which are glomus tumors, metastasis, meningioma, epidermoid arachnoid cyst, schwannoma of cranial nerve, and aneurysm. Then talking about CSF examination, we'll find one thing, that is raised protein levels. Then talking about treatment, surgical removal of tumor is the treatment of choice. Approaches are through suboccipital, retrostigmoid, and then we have basically an translabyrinthine approach and suboccipital approach are also combined. Then middle cranial fossa approach. These are the multiple approaches. And we also have radiotherapy in which we do X-ray or gamma knife surgery. X-ray knife surgery through cobalt 60 source and cyber knife. Yes guys, now we are going to do a fun session in this video, that is question and answer session. For this I'll ask few questions which you need to answer, and then we will see all the answers of this question if you are not able to answer. So what's important in acoustic neuroma which we discussed till now was that the basically first we'll start one by one. So question number 1 for you all is that acoustic neuroma is also known as. Question number 2, most common benign tumor of cerebropontine angle is. What is the site of origin of acoustic neuroma? Which is the most common nerve involved in acoustic neuroma? What are the characteristics of acoustic neuromas? What is the age group mainly affected? And if the young age group is affected, so we can rule out neurofibromatosis by which two conditions? So let's see that. So this is very important, that what is that acoustic neuroma is also known as vestibular schwannoma. Most common site of origin internal acoustic meatus, vestibular nerve, benign, unilateral, unencapsulated, and if it young between 20 to 30 years, it will rule out neurofibromatosis. By in 5% neurofibromatosis 1, unilateral acoustic neuroma, and in neurofibromatosis 2, bilateral acoustic neuroma. Next, clinical feature. Earliest symptoms we have slowly progressive unilateral sensorineural hearing loss in elderly. So you can see over here which are the loss of corneal reflex being the earliest sign, earliest ocular finding due to involvement of cranial nerve 5, afferent more than cranial nerve 7. Nerves are compressed by upper pole of tumor and lower pole of tumor as we discussed. So you can see the nerves compress cranial nerve 5 and altered facial sensation. 6, diplopia. 7, Hitzelberg sign which shows hypostasia of posterior external acoustic meatus in 25% of the cases. And cranial nerve 8, earliest nerve involved is basically cochlear and vestibular. Cochlear is basically unilateral, SNHL plus tinnitus, and vestibular is compensated centrally and no vertigo. Treatment is basically again presbycusis in elderly because of bilateral SNHL, and vertigo, sudden enlargement due to hemorrhage to tumor or cystic enlargement. Investigations, same investigations which we discussed, no variation. Treatment is again same. We showed this based on the size, weight and watch if less than 1.5 cm. More surgical incision 1.5 to 3, gamma ray or cybernet radio surgery. You can see the histopath of cystic tumor, antennae A type and antennae type B. Antennae type A is a compact arrangement, type B is loose arrangement, cystic spaces and bad prognosis. And here you can see the auditory brainstem implant. What is this? So indication is basically neurofibromatosis 2, patient operated by bilateral acoustic neuroma and placed in lateral recess of fourth ventricle and replaces the nerve and stimulator cochlear nuclei directly. So guys, that was all about acoustic neuroma. You saw the histological picture and also the other pictures too. Thank you so much, and thus we complete one of the most shortest topics, that is acoustic neuroma, and in fact the shortest topic of our series.